So I'm going to go ahead, get my screen all set up. Thanks all for joining. Okay. So yeah, like I mentioned, we're hoping for discussion today around really, innovations, our future. There's a lot of leaders here in this space and on our email chain, part of our SIG. And we really do have the privilege of, moving the needle together. So like I mentioned when everyone was joining, Annie had presented at the spring virtual conference around, what our, group has been up to in terms of moving the needle. Hi, Ben. So I'm going to kick us off. I'm going to go ahead and share my screen. Okay. So yeah, so I think we are well aware, certainly, and we've talked about in a couple of meetings this year so far, right? The ongoing challenge of PCP engagement, whether it's time constraints, lack of clarity in roles, perceived workload, is CoCM adding work or is it actually improving efficiency for them? Um, certainly another challenge that we've talked through as a group too is this, increasing clinical complexity, right? What are we doing to really support our higher acuity patients that are historically have more complex needs than primary care is really designed for? And there is limited, specialized training. So, it's challenging, right? Like managing those gaps in severe behavioral health conditions, our SMIs. And obviously crisis response gap, right? Like limited ability to handle psychiatric emergencies. And I think, as Annie spoke about in her plenary session, right? Like what does the road ahead look like for us? As a group, collectively, this year so far, we've been talking about really strict clinical practice, right? What does that look like? Strengthening T-based workflows, role clarity, right? Like invoking the whole team, not just focusing on the primary care providers, but simultaneously making sure they feel confident and engaged, as they're often role models, for the rest of their staff and workforce development. How are we addressing, as a group, shortages of psychiatric consultants and our BHCMs, and really, focusing on training for specialty settings. And one of the most important things I think this group does really well is policy, right? Making sure to expand and simplify reimbursement models for CoCM, really working towards eliminating patient cost sharing. Annie and I were just talking about, right? Keep pushing to make CoCM preventative care. And then, continuing, right? Implementation and scaling, adapting CoCM for our diverse settings and populations. Um, and our group in terms of moving the needle, right? Just so we're all on the same page, as we start to talk about our future in a minute or so. We're all looking forward to, the policy summit at the fall conference this year. And, we've started the CoCM directory really for the purpose of connecting areas of expertise with specific needs. Example, hey, I'm looking to connect with someone, in an FQHC, a teaching environment, treating pediatrics. And I think it's really important that we continue to focus on collecting, developing training resources specifically for PCPs, whether it's a brief instructional video. I know other folks, in other entities across the nation are doing just this. To really increase a nationwide understanding of CoCM as efficient and supportive. And so, Ben, I already gave you kudos for this very catchy topic discussion title that you and Andy came up with, Back to the Future. And I'm excited for you to, really walk us through, like, let's reflect on, where we've come from, because that helps us steer where we're going. And like I mentioned before, there's a lot of leaders in this SIG, and we're stronger together. And really, the goal is to focus on the future and not go backwards, right? Whether it's Medicare transformation, changes to Medicaid coverage and resources. So Ben, I will tag you in. I'll keep my screen shared.
Thank you.
but yeah, I thought it was important to highlight, um, Annie's coverage in the virtual spring conference. Some of you may have attended, some of you have not. I was not able to. So thanks.
Okay, so I'm gonna desperately need your help on this.
Great.
I'm gonna need collectively everybody to help out because this is a sort of a look forward and then potentially what we can do about it. Because I think I've been in a lot of different COCM meetings, but you guys are all sort of friendly faces at this point, and we all have influence. And so my hope is that we look at sort of what the 5 year plan is, or not plan, but 5 years sort of where we might think we will be with COCM. Things like AI, how can that support us? What we need to do for policy, what we can do for education in our to our the people we work for and with. So I wanted to kind of just jump off and say, um, dream a little bit. Where do you think COCM will be in 5 years? So,
Mm.
and I'm going to use that old therapy trick and be quiet until someone talks. Think it's going to be status quo? Verna Little says all states paying Medicaid rates or better. Medicare rates are better. So getting there, Verna, how are we going to do that?
Well, we have 13 states to go on the fee schedules, right? So we have 13 states that don't have the codes on the fee schedule. So that's some work to do. And then we have if you look at the Bowman paper, a significant number of states do not pay at 100% of Medicare. There are some that are well below that, and so that dramatically impacts, adoption. Um, Also, I'm going to add the CARE Act. Recently got a little delayed, but that would actually be on the federal side. And then the supportive action that most of us signed to help increase the Medicare rates. Hopefully that will be a thing in 2027. So that's uh, my piece.
Okay, so we have some chat ideas, Verna. And Jennifer, PCPs think of COCM, IBM as bread and butter primary care. It's just our new normal in primary care. Do you want to speak on that, Jennifer?
Yeah, sure. Sorry, I'm scarfing lunch, so I'll save you
Oh,
my
no
camera
problem.
chewing face. But yeah, I don't know. I'd like to envision a world where, PCPs, like integration is just normal business. It's how we take care of people, whole person health, right? It's not this other entity. It's just part of the what we do is routine, rank and file, behavioral health is what we do, and that our teams are reimagined so it's not an outlier or that's cool, novel that you have a BHCM. It's just, nope, this BHCM is just as vital to my day as my MA. That would be amazing.
As vital as an MA. Boy, that's a great concept. Um, then we also, Nicole, this is more familiarity with the model. Nicole, you want to jump in on that and say, is that providers or is that patients or both?
Across the board, actually, I think piggybacking a little bit off of Jen, I agree that having this just become the new norm in primary care, having wider provider familiarity, I think we'll start to see in educational institutions this being a part of the education individuals receive, whether it's the physician, the psychiatrist, or the mental health providers, this being something that they start to learn about a little bit more so that when they're exiting school, they they enter into practice, this is something that they've heard about before. They might have some level of familiarity. There's also more accessible training opportunities out there now that, broadens the education related to the model and facilitates, easy access training for those. A couple of different levers like that I think are really important, some workforce initiatives that are happening right now. I don't know if in 5 years, though, this is going to be the new norm. That might take a little bit of time to get it into all of those education institutions and, really work on some initiatives there. But in general, I think access to information and training about the model is a little bit more widespread now. So I think we'll start to see an impact there.
I
So
guess
we need
I
a
would like
national
to.
marketing campaign. And I interrupted somebody who was
No,
speaking.
I was getting ready to
Oh, go
chime in
ahead,
for a
Gretchen.
second. So I think what I would like to see, since I'm actually in specialty care, I do maternal health, is that we see more broadening in the specialty care arena as well, just because we've had a lot of success in our clinic. So seeing, like, knowing that it can work well and that it has worked well, like how do we get that out there so people can, think about doing more in specialty care, even if it's oncology or, I don't know, cardiology, whatever, like just knowing that it can be implemented well in a specialty clinic also. And just like seeing more of that moving forward.
Yeah, fantastic. And so Laura, can I pull you out on that AI thing? Because that's one of the ones I was going to say, but do you want to jump in on that comment?
Yeah, I mean, I think we're still like doing kind of a public health experiment with how AI is being used. And we've seen concerns, for instance, with people using AI as a therapist or as a romantic partner, and the challenges as well as very deadly concerns, including a death by suicide that was in the news in Florida. And so I think AI could really help with concurrent documentation, streamlining in ambient ways our check-ins with patients. However, we need to see also safeguards on that related to if we're having AI be just sort of a mirror reflecting back for patients that can reinforce problematic thought loops. If we have concerns with a patient asking for something that's not in their best interest, there's not great safeguards on that. So I don't really see those in the next 5 years meeting the important ethical bounds that we have as humans. So seeing more opportunities to fill those administrative gaps while also making the operator kind of like we have for like nuclear bombs. We don't have AI or computers push that button, making it very clear that we need those buttons directly with patients being clicked with humans.
And I was thinking of AI as being also population health and patient identification, using it for that tool where they could, when we all scrub the schedule, that could be done pretty easily with AI and things of that nature.
Yeah, registry management as well, identifying referrals, people for psychiatric case review, all of those could really be augmented with AI with good safeguards.
Excellent. Kate, can I throw you out one of my most important population, I think, was pediatrics. Do you want to jump in on that comment?
Sure. I sort of called out the penetration of child psychiatry access programs because, like, the original reason that those existed was to be able to have more behavioral health treatment in primary care by having remote access to expertise, right? So this is sort of a, a um, an opportunity to grow that idea. And so I just think, like, in pediatrics specifically, there is that, like, foundational idea that there's never going to be enough specialty care. That's a presumption that specialty care is better than non. So I'm just putting that out there but so let's figure out a way to solve this problem. That's like MCPAP in Massachusetts. But now, as of this year, every state will have, and like the Pacific Islands have their own child psychiatry access program. So thinking about using the same logic, supports, et cetera, that really happen within CoCM to move the needle further and to move practices, like to use their having taken up the child psychiatry access model. And there are states, right, where actually there are COCM lives in the child psychiatry access program already. And so I just think like, it seems so clear. It seems so like there's already infrastructure, there's already humans, there's already, right? And then you layer on like we have AI tools now that can decrease some of the things that are more challenging from a like workload perspective. Yeah, it just feels like I would like to see the same kind of momentum, having been around from when MCPAP, which is Massachusetts, was like the first program, to now it's like run of the mill thing that's in every state. So I'd like COCM to have that same momentum.
Question for you, Kate. Do you feel like pediatricians are utilizing the CPAP? I don't know, just comment for my system. My pediatrician's like, we don't use it. And I'm like, why don't you? You have a access line, you got a bat phone to a child psychiatrist. And like, well, it's clunky. It doesn't, if I'm in clinic and I have a question, I got 3 patients still waiting for me, and then I have to play phone tag.
It depends on the practice, the relationships. I don't know where I went. Oh, I went over.
You're fine.
I'm like, where did I go? It switched cameras on me. Hang on, I'm gonna move you guys so that I'm.
Yeah.
It totally depends on the relationships, the model, the state, what is actually being offered through the CPAPs. So some of them have been more responsive. It also depends on how much of a desert they're functioning in. I think that, we like to complain a lot here in Massachusetts, but we have a lot of people who like more work, right? More mental health workforce, child psychiatry, et cetera. So there's a bit more tendency to just refer to specialty care instead of, so what I would say is it's all in our network. I can speak specifically to our network, but I can also speak from my like national perspective I came from. It's all over the map.
Okay.
Literally all over the map.
Okay. Yeah. Anecdotally, one of the things I like about psychiatric consultation in I guess e-consult model is I get the input in the chart from my psych consultant. When I've called the CPAP line a few times, we talk over the case, and it's at the end of the day or the next day that we play phone tag and she calls me back. But it's always, oh, you could try this or blah, 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 but it's not documented. And then I don't get the same person if I have to call back. Because inevitably in primary care, there are problems and they're on our herd and they're going to keep resurfacing next week or next month with, oh, I tried that, didn't work. Or parents are like, nope, that made my sister crazy. I hate the stigma word crazy, but people have these preconceptions around meds sometimes where we don't often get a slam dunk answer with the first med trial. So it's nice to have a consistent, I'm not throwing shade on any model of integration. I think all comers, all flavors are woohoo. But what I do like about having a consistent site consultant is I know that that's a partner of mine where I can call them back like, hey, remember Susie last month? We said sertraline. Ain't gonna fly. And now there's trauma. What do we do with her? And then I see her note in my chart. That's been really, I do appreciate that as a PCP, just sharing.
Yeah, we just had, our statewide MCPAP just had a meeting, and the need to send documentation of your consultation is a direction that they're like the changing from thinking of themselves as educational, which is where it all started for a variety of reasons, to thinking more about the fact that they actually are consulting, right? They're actual consultants. So it's a hot topic.
Imagine if that network could be psychiatric consultants for COCM.
You betcha, Ben. You betcha.
Coming up to Patty's comment, I can speak to this personally. So about value-based care contracts. So we at Janus have several value-based care contracts, and we get shared savings reimbursements from those. The very difficult part is finding out the metrics that you choose to base those shared savings on. But when you're reducing hospital visits and reducing ED visits, that's saving a lot of money, and it's been pretty successful. So I don't know if anybody else has experience with value-based care contracts? Maybe that's the direction in 5 years, huh?
Just a comment on that. Oh, Kate, you were going to say something.
No, I was
Comment
just
on
giving a
that.
+1. I was just giving the +1. I wasn't going to say anything.
We're everybody knows this directly. We're still working on Arkansas Medicaid to get the codes turned on. And especially with the Medicaid reimbursement going down, they don't care about future return on investment. They care about what's it going to cost this year. But also, a lot of states that do have codes turned on, there's still a slow implementation. And as we try to think about implementation, this needs to be part of the overall primary care, not like a carve out fee for service procedure. So that's why I'm wanting to move more toward value based care. However, it is so clunky the way the current contracts are, like you said, Ben, like who gets the money, who when there is shared savings. And then the third thing I would say is really, as I'm realizing, so much about collaborative care is cost savings. And most of the insurance payers who care are the ones who have long-term responsibility for the patients. So when you're talking about a commercial plan who has just employees that may not even be there by the end of the year, then the insurance companies just can't have an investment in preventive care, spend money now because they might save money, but it won't be their patient. So that's why you're seeing it in Medicare or VA, or managed care plans or capitated plans. So needing to get our mind around that, of how to show the value, because there is value in decreased ER visits and decreased hospitalization, but you have to not scare the hospitals thinking they're going to lose income. But there is a video on the AMA website from UC San Diego that shows that they had improved revenue into the hospital. So just wanting us to be reminded of when we say, well, the insurance company should be happy because it saves money. It depends on who is having to take care of that financial responsibility in the long term. And that's really one of those kind of should have had a V8 moments for me of realizing, because I've been teaching. This saves money. This is good for the patient. This is good quality care. But it's a business. It's a business for everyone, the payers as well as the hospitals and primary care. So, so I'm just throwing that out there because it's like an aha thing I've just been realizing, and how can we get our minds around it?
I think the only way to like get anybody's mind around that is to think about the ROI, not on an individual basis, right? I'm not saying anything anybody doesn't, right? Like you can't make an argument about an individual person. You have to make an argument about a population. And that it's not about you're investing in this here population and then this here population is good, right? But you invest in a population, people move in, people move out, but the overarching trajectory is the right one. Because I totally agree with you, especially with the payers where, the average length of staying with any commercial payer is like 10 months or something. So it needs to be a model that, and with kids, it just gets even more complicated because like the ROI is in the wrong pockets. And so, not spending money on special education outplacements is a great outcome that we might understand, but it's not showing up on the Medicaid books or on the insurance books or right. So story of my life.
Well, that was just a aha moment, that Jill's interaction. That's fantastic. Patty, you had another comment about all BHI are blended programs. Did you want to speak to that?
Yeah. And Laura and someone, I'm sorry, I can't remember who else. They just put a article in the psychiatric, one of the psychiatric publications, but just seeing the true value of having that BHC with the PCBH model to be blended in with the CoCM model. I mean, I know that's the Cadillac, but that is a way of making the overall BHI and being part of the team, the primary care team, to be able to have both.
Gotcha. Um, Laura, it looks like you wanted to talk about the CPAP logistics are well, lack of consistent
Oh, I was
ratio.
just validating that point about sort of the CPAP challenges. I think it's such a great service, but it's like the logistics of having to call in and be able to wait, even with the safeguards and supports they put in. And then I've really liked getting to talk to certain psychiatrists, but you can't request somebody. So it's like if you consulted with somebody before, you're not guaranteed to get that person again. And so part of the consultative support you get as a primary care clinician is having that relationship with your psych consultant. And it's an area that I think there's a lot of room for improvement still on how we can create some continuity relationships between our consultants. Not just, kind of think about that as with our patients or with our care managers, but the site consultants, that relationship is really valuable.
Excellent. Laura, I'm going to call on you again because another comment. So I'd like to see some additional innovation surrounding ways to capture progress in patients who the reality is they're not going to improve in symptom frequency, and are showing progress in symptom management and functioning. That's interesting.
Yeah. On the two dream sheets, like one would be preventative care. So using like a capitation approach and like really if we could get sophisticated with not just improving scores, but maybe like maintaining them low, that could be a really great opportunity. And then the other part would be we have some patients, especially in community settings, who they live at like a PHQ-9 of a 15 because they have all the vegetative symptoms are high, but they make tremendous progress in terms of symptom management, reduced ER visits, all these things that like if you look at improvement from the perspective of PHQ-9s or GAD-7s are not making it, but they're doing better. I know there's been some innovation around using the HUDAS and some other screeners, but I think we have a lot of opportunities to get more sophisticated. I've got some patients also that they never are going to link with specialty mental health and they get better during their episodes of care, but then they decompensate and we catch them too late. So for some of those people, they're going to be long-term supports with CoCM, but through an episode approach. So different from 15 years of psychotherapy, we have some people who now in 5 years of care have come back for multiple episodes and getting them back in, let's say at 6 months instead of waiting for them to really decompensate and come in at 8 or 9, we've made a lot of improvement with some of those individuals. So I think those are other areas that in the future we have opportunities to do better with CoCM and capture on those.
Couldn't agree more. The functional piece is so missing with our current metrics. I mean, I like a PHQ-9 like anybody else, and I use them. I never did. Now I do all the time since collaborative care. But we're missing something with functionality. And if we're going to do it, HUDAS, I briefly looking into it, it's kind of clunky. Lately, I've been thinking about operationalizing the Sheehan disability scale. It's got to be quick. If it's going to fly in primary care, it's got to be fast. So I think this is something we need to look at collectively when we have our registries of, yeah, PHQ-9 scores matter, but so does, did you get back to school? Are you leaving your house? Those things matter just as much, I think, on just are you better? Because yeah, to your point, people can over-report on a PHQ-9 all day and they're not a 20, so I don't know. I just think we need a functional brief scale that we need to really bake into the work of CoCM for sure.
Well, you also could do health behaviors as well, and gaps in care, as well as, those sort of, are global sort of health as well. So it's not just mental health, but, getting off of just the PHQ-9 and GAD-7 sounds like a great idea.
And like I feel like they're leaning in more, like the NCQA meeting I was at that's looking at these big national recommendations on metrics that are going to inform value-based care, they're leaning in hard to PHQ-9 scores. Like you look at their recommendations on depression screening and follow-up, it's all PHQ-9 data, which is good. I mean, it's better than no data, but it's just fascinating to see that like these big entities are really leaning into this is the thing we're measuring. Like, okay, measure that, but maybe also measure some other things too. That's just my 2 cents.
So, I think talking about innovations, so technical innovations, we talk about AI, are there other innovations that we need to think about as far as, the registry innovations, some, some continuity between registries that would support the whole process, anything of that nature that folks could think about that they would dream to have in the next 5 to 10 years?
I just saw Julie, you had your hand up.
Oh,
So, yeah, I mean, this might be something that other people have managed to deal with. I work at a really large teaching hospital in New York City, that is pretty rigid with compliant, very, very rigid. And one of the things that I was thinking of that in a perfect world in 5 years in 1 year would be, so right now we have, someone had mentioned like, more of a melding of behavioral health integration and collaborative care. We have some parts of our system where all they have is collaborative care, and it's sort of like an easy, I don't want to say, it's like an easy decision for the provider to make the referral. Where I work, we have behavioral health integration and collaborative care, and the providers know something's going on with the patient, and they don't want to click one button or the other on the referrals, but because of the consent, we haven't been able to, like, we've condensed every psychology, psychiatry, substance use, everything else into like an on-site adult psychiatry button. But collaborative care has to be separate. And we have a big presentation about it tomorrow. And, everyone is requesting, can't we just press one button, send to you guys and figure it out? And at least which makes perfect sense, at least our compliance folks are very, very focused on the consent and how the consent and when the consent has to happen. So okay, that's really good to hear, Laura.
Yeah, you build the bowl that holds both the fruit. So everybody gets consented. And when I've had people be like, oh, well, when I send them to pulmonology, I don't have to consent them. Well, that's a great opportunity to provide education about BHI being part of the team and us bringing patients in or bringing in clinicians, not referring out. And that's worked very, very well for exactly those concerns you're describing. And some people force everybody to go through BHC versus having the ability to choose. We've kind of gotten around that by you can choose one or the other, not both. But if when in doubt, just start with the BHC and really encouraging warm handoffs.
Or use a general and I'm sorry, I want to take it, but the consent that our system would be psyched if, we didn't have to do this, like our consenting, our folks are very focused on the fact that we have to mention the cost sharing, but the cost sharing is only applicable if it's billed under primary care, right? Not necessarily, you all know that. So I guess we could just put it in there anyway as a maybe, and then the providers would just, like you're saying, consent everyone like a blanket consent.
Verna Little's not on this call now, but she's the one who taught me this approach for the cost sharing. So you explain it the same as medical care. So similar to your medical care, you might have some cost sharing, such as with a copay or what your insurance describes is needed. However, we have good success parring with all of our different payers, and it's similar to what we have for medical care. So you're normalizing it. So yeah, you're having that conversation, but I think it's a problem if we put it out like something abnormal or something like different. And we've had pretty good success with doing it in that fashion. It was more of like the resistance until we just said, look, across the board, we're doing universal consenting. And then it seemed like all those complaints went away. It didn't seem to be as big of a problem anymore.
Okay, thank you. I'll reach out to Verna and I might reach out to you. Thank you so much. Thanks, everyone.
I think Monica has her hand up.
Only because I was going to add, since Verna's not here, I'm literally over here stuffing my face. Hey, everybody, it's so good to see y'all faces. So, the reason why the cost sharing language was put in there and became such a big deal is because this way of providing service with collaborative care, where it's built underneath the medical provider, but here's this other person doing the service, and some of this service is not even going to include face to face time, which, when you really think about it, a lot of how medical functions is the face-to-face time. I see you, I bill for that. I see you to do this, I bill for that. So the cost sharing, really, the thing was they wanted to make sure that patients knew and providers knew someone's going to be doing all these things and you may have a bill. Oftentimes when providers are concerned about, like, I don't want to be the one explaining this to the patient, I remind them, when you get lab work done, you have no idea how much your patient is going to have to pay. You suggest the lab work because it is clinically indicated for whatever condition you're trying to treat them for. The patient gets to decide, yes, I'm going to do the lab work, or no, I'm not going to do lab work. But you as a provider have absolutely no way of knowing how much it's going to cost. Even in behavioral health, if you kind of swing to the other side, when you're seeing a patient, unless you call in advance, which most behavioral health organizations do, you actually too have no idea where your patient's going to end up, because all insurances, you've seen one Blue Cross Blue Shield plan, you've seen one. There's just so many different nuances to them. Sometimes the behavioral health is managed by somebody else that isn't even Blue Cross Blue Shield. And so because of all of those nuances, like, no one really could tell a patient, here's exactly how much you will pay, unless you call, say, every code you're going to do for that patient, and then someone tell you how much it's going to cost, right? So the cost sharing thing came about because this is just a different way of providing care, and they want patients to be aware and providers to be aware. And so when you really think about it, in a lot of systems, medical providers give that initial, whether it's they handed them something with the cost sharing language or they're talking about it. And then usually in most systems, we see the behavioral health care managers also spending time kind of re-explaining, because they want to make sure that patients get it, that they understand that this accumulation of minutes that are going to happen, that could be time that spent me and your provider talking about you and you're not even there at all. But there's a portion that you might be responsible for. And it's just wanting to make sure that everyone is aware and in the loop. How you do that, it actually doesn't give you direct directions on how to talk about the cost sharing. It just tells you that you need to talk about it, right? And so some people do have scripts that they give their providers that are really brief and short. Other people have in a written handout that they're handing to a patient. I've had some people that have had it printed out on their after visit summary. I've seen all kinds of different ways that people are meeting that requirement. It is something that people are just nervous about because it's not our normal way of doing business in terms of talking about it. But we have been doing that for quite some time, recommending services and having no idea how much a patient is going to have to pay and all of those pieces.
Yeah, I think we could get our providers to do it and be comfortable. It's our compliance folks who they want written consent, it's a lot. But this is all super helpful. I'm copying and pasting all this. Thank you.
Maybe I'm outside the norm here, but would consent be, if we can get consent by folks other than the primary care, wouldn't that help our field a lot? We can have MAs do it, social workers, anybody.
Yeah, I mean, there is for FQHCs, they're kind of given a pass, right? Like in the FQHC world, it could be the BHCM that has that
Oh, I forgot about
conversation and
that.
gets that consent. I think it's one of those things when we are advocating for certain things with Medicare, it's something to continue to make sure we don't leave off the radar and we advocate for a change in that. I think, like I said, I think their premise was they didn't want medical providers to not be aware these services are happening and going to be billed underneath you, because we all know and probably have heard of incident to billing horror stories. They do exist. And so I think, this was a kind of compliance, legality, let's help situation. But for our FQHC friends, they have not had to do it this way.
Maybe we need to get those folks to help everybody else to understand that it's not a big problem. Um, let's see. So we have some agreement from Ashley and Laura on that. Any other hands up? Any other comments? Michael, you had made a comment earlier. I think I may have missed it. Oh, it looked like it's just agreement. Did you want to speak to that at all? Oh,
No, no, not really. I think everything has been spoken to, um, on that subject as far
gotcha.
as consultations with psychiatry. Yeah.
So what kind of risks do you think that are headed in front of us to our CoCM um, world? Do you think we have any risks of policy or legislation or things of that nature that could risk our actual progress in the next 5 years?
Well, I'll throw out just one thing, just would like to see where the psychiatric prescribing is heading right now. Because I know, the psychiatric consultant is, one of the corners of that triangle, right, for CoCM. But if there's big incentives not to prescribe, being forced by policy, then I think the model loses some oomph.
Um, I know there's been a lot of conversation about that recently, and I think something that I've also seen conversations around is where the model also lends some additional guidance to providers for having additional information and guidance when prescribing, which I think can also be in favor of this model in a way. I think there's kind of things on both sides of it. There's things that could, put the model in peril, but also this model helps PCPs have a little bit more and specialists have a little bit more information when they're prescribing to pediatric populations and adult populations so that they're monitoring that medication a little bit more closely and adjusting and making sure that the diagnosis is appropriate for the patient. So I think that's also an interesting edge that collaborative care also has compared to other models.
Excellent. Does anybody have any updates on the CARE Act? I think Verna said something like it was delayed. Does anybody have any updates on that? Nope. All righty. So that's all the questions I have for us. Ashley, if you want, do we want to kind of give them some time back, or are there any other questions or concerns people want to talk about?
Well, I just want to say I've really thoroughly enjoyed this conversation, hearing from all of you and what you're hoping to see for the future. Like I said before when we first started, right? Like we're certainly stronger together. Um, and being able to have these conversations, it's inspiring to be among all of you, um, who, think with such intention, right? And learn from each other. So I hope everybody, has certainly found this valuable. I can't wait for us to meet again. And yeah, I think we can give some time back. Patty, are the virtual CFHA conference recordings still available? I am not sure. Is Hannah still on? Do you know,
Yeah,
Hannah?
the virtual recordings are still available. You can still register even if you haven't yet and watch those virtually. You'd still be eligible to get the CEs virtually, or if you already attended but want to watch the sessions you didn't see live, you can access those as well.
Awesome. Thank you.
Some excellent presentations, including Dr. Sederi, Dr. Thomas, doing one that went into a lot of good detail on the role of the whole spectrum of the role of the psychiatrist. And then there was some that Verna went over the latest policy things, and then quite a few other ones very specific to CoCM, but also, of course, the multiple topics. It was a very good conference worth plug it into. So if you watch it on your own time, I recommend it.
Thanks,
Mm.
Patty.
And Nicole put in a very good resource, free resource. If you want to talk about that, Nicole, real quick.
Sure. We just recently released these. I sent a message earlier, last month about these, so you might have already taken a peek. But in partnership with West Health and Northwest Medicine, we developed some free online modules to help train different roles within the collaborative care model. So we have one for the behavioral health care manager. It's 3 hours long. It has subject matter experts talking about their experience in the role. It has a lot of great interactive materials, an example patient case. We have one for the psychiatric consultant role, one for the PCP role, and it also focuses in on the primary care champion, which I'm really excited about. I think it would also be appropriate for specialists, so definitely, encourage taking a peek if you're working with specialists. And then we also have a really exciting billing module that I like. It's built with a couple of different roles in mind, so it's not just for your billing folks, your BHCM, if they want to learn a little bit more about billing, it would be great for them, the PCP, anyone who's curious about how all of that works. It comes with CEU and CEU credits if you complete those trainings. So definitely encourage taking a peek since, free is always nice. And also, hopefully the materials are helpful. And if anybody has feedback as they're taking it, I'd love to hear it because, really helpful to just learn and adapt the trainings to best support this wonderful group of folks. Sorry, that was long-winded.
Fantastic.
I also put in the link to the ABN conference that has some good recordings on the site, including Dr. Thomas, as well as Sulamita gave a very good presentation on the 5 steps for the financial implementation of CoCM. And then Chris Botts is on there talking about the latest with the AMA. And the AMA has done some updates that include the compendium, of course, is updated. And then again, I'm saying Dr. Sideri and Dr. Thomas, who are our CSHA co-medical directors, did an excellent toolkit. And we always see toolkit, but this toolkit has for real, really good links in it that are usable. And even though Laura and Jennifer are my friends, I'm saying this just from a clinical, that is an excellent resource for anybody. So for your trainees, your PCPs, or for anybody. So go to the AMA website.
Well, thank you very much, everybody. We've got a lot of resources here. Oh, Laura has one more.
Just throwing that one out from Patty. Thanks for the shout out.
Perfect.
Excellent. All right. Well, see you guys later. Jennifer did throw out there that the registration is open for the fall conference. Looking forward to seeing you guys there. It's one of those conferences I would never miss.
Well said. Thanks,
All right.
everybody. Take care.
Take care. Thank you.
Thanks, everyone.